everyone. Welcome to this edition of the Asia Ventilation Forum, or the AVF Behind the Scenes ICU Stories podcast. My name is Jason Puar, and the topic today is the future of intensive care. We have none other than Professor Jean-Louis Vincent with us today. As many of you would know, he is the Professor of Intensive Care Medicine at the University of Brussels. He is past president of the World Federation of Societies of Intensive and Critical Care Medicine, or WFSICCM, or WFICC, as well as past president of the European Society of Intensive Care Medicine, or ESICM. He's the editor-in-chief of the journals Critical Care, Current Opinion in Critical Care, and ICU Management and Practice, and member of the editorial boards of about 30 other journals. He has authored more than 1,000 original articles, and his H index is a whopping 193. So, Professor Vincent, thank you for joining us today. Prof.
Thank you, it's a pleasure.
Thank you. Yeah, Professor, you have been there, done that, right? You have seen intensive care evolve through the decades, and you have the vision for the future of intensive care as well. So just one broad question: what do you see in the future of intensive care?
Wow, yeah. Well, first of all, thank you for inviting me to address your audience. But this is a very wide question, and it may take 2 hours actually to discuss all the elements, because there is a lot to say. Our future is bright. Our future is exciting. There will be a lot of new developments in organization, quality of care, organ support, communication rounds in the ICU, ethical aspects, artificial intelligence, telemedicine, diversity, and other elements. So, okay, maybe I can try to start with some general concepts, which are that our discipline will expand, and not only in the intensive care unit, but also outside the ICU, in the hospital, in the ambulance, in the community with telemedicine. So I like the American words of the intensive care unit and critical care medicine. As you say, I am a past president of the European Society of Intensive Care Medicine, because in Europe, we usually speak about intensive care. It's okay. But the concept of a broader specialty, I think, is very adequate, because we will have a role to play in communicating with our colleagues, training them to face the problem of a patient getting worse in their department or elsewhere. And we will have to play an increasingly important role in the hospital by looking after the patients who may deteriorate. And we all speak now about the rapid response systems, RRS. Some people speak about rapid response teams, but the abbreviation is RRT. That's renal replacement therapy, so that's not good. That's the reason why I prefer rapid response systems. And that's something that we will definitely be involved with more in the future than in the past. When I tried to convince our colleagues here at the Erasmus Hospital in Brussels that we needed to go out and evaluate the patient on the floor, whenever we were called, my colleague said, "Oh, no, we're already so busy here. You want us now to go to the floor in addition to what we do here?" I said, yeah, because it would prevent some admissions in the ICU. So we will have less work in the ICU if we can identify the problems early. And clearly, the monitoring systems in the future will allow us to do it in a much better way without any discomfort for the patients, because it will hardly be invasive. We are speaking about pulse oximetry plus heart rate monitoring plus plus temperature assessment. The nurse will no longer have to go into the room on the general ward every hour or every half an hour to take the pulse and take the temperature. Oh, no. All of this will be done automatically and will appear on a big screen in a central station of the hospital. And combining variables will minimize the false alarms, and the integration of these signals will be much more meaningful to trigger our response. So I think that many patients will actually avoid their stay in the intensive care unit through this early recognition of the problem. Now, there will be more critically ill patients because medicine is progressing. We have more and more elderly patients. We will have high-risk procedures. So we will still have enough patients in the ICU. No discussion about it. And I think that for some parts of the world where it's not the case yet, the ICUs will be departments, but they will combine medical and surgical ICU patients together. The American system of the medical ICU, the surgical ICU, that's over. The problems are the same in medical and in surgical patients. But hopefully it's already like that. In most places in the world, you have only one general department of intensive care. Now, in the departments, the communication will improve, and I think we will make better rounds altogether, because people still like us to discuss this, how we organize rounds so that they can benefit the patient, of course, and make sure that there is enough teaching for every member of these multidisciplinary rounds: doctors, nurses, students, physiotherapists, whoever is part of the team. And, again, whenever we want to speak about it, people are really eager to go to this room and attend the discussions. But that will certainly improve, because one of my, how could I say, strong opinions is that personalized care will be the future, and protocolized care has its limitations. And yet, in some places, people would like to protocolize everything, especially in many places in the US, where they lack ICU doctors. They would like everything to be in the computer so that the nurses can drive the system. I think that's not possible, because we do not have enough evidence. People love to have prospective, randomized, controlled trials, and I do too. But the problem is that in many pragmatic trials, people enroll very heterogeneous patient populations, and they end up with negative results. There is no difference between the two groups. And so those who are critical will say, oh, it doesn't work. Oh, no, The Swan-Ganz catheter, no. Transfusions, no. Blood pressure above 65, no. Simplify, etc., etc. But when you are facing a patient, you start to think, there is sepsis, but what is sepsis? There is a lot of heterogeneity there. There is ARDS, okay, but what is ARDS? There is no specific treatment of sepsis besides antibiotics, of course, but for the host response, except maybe for corticosteroids in severe cases. Otherwise, there is nothing specific in terms of sepsis therapy. And for ARDS, there is nothing specific. There is a strategy to avoid harm, to keep tidal volumes relatively low, etc. I'm not denying this, but once you put the label ARDS at the top of the bed, if I may say so, it will not really inspire some very specific action. So individualized care, personalized care is the future, and hopefully artificial intelligence will help us with that, because with artificial intelligence, we will have, of course, easier access to a diagnosis, but that's in medicine in general, not specifically for care. We will have some direct information about the optimal management based on a number of variables that will be integrated. And artificial intelligence systems will allow us, and I already alluded to that for patients on the floor, that will allow us to have a time course of events and may tell us, be careful, this patient may actually go worse. That's what we do now with repeated lactate levels. We want to make sure that the lactate levels go down with time, that they do not go up. Some people call it lactate clearance. No, it's not clearance. It's the time course. It's production more than clearance, but you look at repeated lactate levels. But lactate is just one variable among so many. And so we will be able to integrate more of these elements. Our problem now is that we have neglected a little bit personalized medicine. We have seen the recent Surviving Sepsis campaign guidelines. I love sepsis guidelines. We started them in Brussels. The first one were written here in Brussels back in 2000, and I have been part of the committee from the very beginning, so I'm not criticizing. I'm saying that when we are 50 people in the room, it's becoming very difficult to make strong recommendations other than don't do that, not necessary. And at the end, people say, okay, but I still have to treat a patient here. How much fluid should I give? What would be the optimal blood pressure level? When can I avoid sedation? Sedation is very bad. We should avoid it whenever you can, etc., etc. When should I intubate the trachea? No, we could tell that this should be based on a number of elements. Of course, there is no simple recommendation, but there are some recommendations that could really be provided. So, sepsis ARDS, I think we will go into phenotypes with biomarkers. We will try to better characterize our patients and therefore identify the right drug at the right time for our patients. We have so many negative trials in the field of sepsis or ARDS because the populations were too heterogeneous, and also because we focused too much on mortality. And mortality is influenced by many factors: age, comorbidities, underlying problem, and patient preferences that may be expressed by the relatives. But sometimes patients will be allowed to die when in other circumstances we will continue and send the patient in a very weak state outside the hospital, or the other way around. Sometimes, we send a patient who will remain comatose to a special institution, whereas in some hospitals, including ours, we may have preferred to stop therapy and allow the patient to die rather than going with a quality of life which is almost zero. So these elements will definitely be more developed in the future. Now, telemedicine will change our world. Also, if we have difficulties to find doctors at night, initially I was very opposed to the American idea of telemedicine to help to guide therapy in the ICU. But thinking about it, it's not a bad idea at all. It's actually quite interesting that our friend Tim Buchman from the US sends his doctors to Australia to stay there for 1 month. And they work during the day over there, which is the night in the US. And by telemedicine, when they are well awake, they can spend their hours monitoring patients in the ICU, helping the doctors there. That's a great idea. Of course, you still need doctors there, but they do not need to have the full training if they have someone supervising them. And that's really something that I believe in. Ambulance transport. We all have different ambulance systems, but in Belgium, we bring the patient to the hospital as rapidly as possible. And sometimes we call for medicalized ambulances, having a doctor in the ambulance. It's not necessary to have a doctor in the ambulance if you have well-trained paramedics with a telemedicine system, with doctors from the hospital capable of helping people who are in the ambulance. And we could perhaps already do something in the ambulance if, of course, the duration of the transport is relatively high. If the hospital is just next door, it may not be applicable. But in regions where there are relatively long times to go to reach a hospital, we could perhaps even recognize the need to give antibiotics in the patient with sepsis. I reviewed a paper in the Lancet which is negative about antibiotics in sepsis patients in the ambulance, but the patients were not septic. They had a minor infection. They had a mortality rate of less than 10%. Less than 10% went to the ICU. So no, that was not sepsis, my friend. And so people usually say, oh, maybe that's a negative study. It was a wrong idea to give broad spectrum antibiotics to patients who just had an infection. I wrote the accompanying editorial and I raised this point. But I read other papers like you from Canada saying that we could give more fluids in the ambulance. Okay, interesting. We can work on that. Or I just read a paper which is not a prospective randomized controlled trial, but this observation suggested that the administration of vasopressor agents a bit earlier in the ambulance could actually perhaps make a positive change and improve outcomes of these patients. It's just the beginning, but I think that this is something clearly of interest. Instead of waiting for the patient arriving in the emergency department, and we could also call for the cardiologist in the case of myocardial infarction, or the neurologist if it suggests to be a cerebrovascular accident, etc. So with the developments of artificial intelligence, the doctors will probably have a little bit more time, and that time will be used to discuss more with the relatives and with the patients, of course, if they are conscious and if they can interact. So we will make a more humane medicine. We should be happy about it. We'll have more time to discuss about the various fundamental elements, including the questions of end of life and when we should stop what they call in English futile therapy. In French, we prefer to speak about acharnement thérapeutique, which is therapeutic stubbornness, which is a better word to describe that situation. So that will actually help the patients and their families to understand all the issues associated with the acute illnesses. And having less workload on doctors will allow people to have a better quality of life, including doctors and nurses. And that, of course, is something that people are very concerned about. They don't want to spend hours and hours in the hospital and go home at midnight being totally exhausted, as it was the case when I was a student, before I was an intensivist. There was no good organization, and the people from the previous generation sometimes had to stay in the hospital and come back during the night regularly, etc. Now it is less the case, and it will be less the case in the future. And this will attract more people in the ICU. People have sometimes experienced burnout after the COVID-19 crisis, but hopefully there will be more people, the systems will be better organized, people may be paid a bit more as well, and so, okay, we will get over that for sure, but still, the doctors will come in the ICU if they have some time off, some weekend time, some time to spend with their children and family. That brings the question of diversity. Right now, at the junior level, we have a number of women who are interested in critical care medicine, but when you go up in the hierarchy, many women will abandon. They will say, oh, I like it, but I don't want to have your life, as people sometimes say. I don't want to be to do too much and to be exhausted. I want to have some time with my family. And so people would like at meetings, in scientific publications, in the editorial board of scientific journals, to have more women, more, and they are right. Yes, we need to have more women, more diversity, absolutely. But it's by helping people to have a better life that we will really attract people with different backgrounds and with different preferences that will still like to work in the intensive care unit. So there is much more to say. If you like, I can even address the question of organ support. We published in the JAMA now a couple of years ago about the concept of ECOS, ECOS, for extracorporeal organ support. The idea being that in the future, we may not have to intubate the trachea of every patient with severe respiratory failure. You will say, okay, we'll have masks for non-invasive ventilation. Yeah. There is something along these lines. But when you look at the development of extracorporeal membrane oxygenation, ECMO, especially with COVID, and when you see how people have been able to apply it routinely in many institutions, well, that could be a way to replace invasive mechanical ventilation by an extracorporeal system. And you can look at your smartphone, you can read a book as your blood is being oxygenated. I enjoyed very much the case report in the American Journal of Respiratory and Critical Care Medicine last month from Paris, from Alain Combes' group, where they describe a patient with severe COVID-19 who could avoid endotracheal intubation for severe respiratory failure, but could be treated with ECMO without any endotracheal intubation. Isn't it interesting? And perhaps in the future, we will have these very simple systems that perhaps we will use on the floor. Who knows? Not next year. No, no, no. In some years from now, maybe patients with decompensated chronic obstructive lung disease with COPD will receive the treatment to eliminate their CO2. And when they get better, we remove the system and they can go home. And for renal replacement therapy, if you think about it, we can simplify these systems and we could have some smaller material that people could even wear at their wrist, at their belt, and go home if they are still in chronic renal failure with these systems that could purify their blood in the presence of terminal renal failure. So this is really very exciting. And with ECOS, you could actually combine different elements, better gas exchange, renal replacement therapy. You add some calories with some parenteral nutrition. You can eliminate some excess of mediators, but because you do some purification at the same time. And we may even have a pump helping your heart to pump more. And so it's not futile therapy. No, 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 no. It's helping patients to go over an acute period so that when they recover, you can remove these systems, or at least most of these systems, and hopefully they can go home. And when I say I can go home, some people can go directly home from the ICU nowadays. I was surprised when I saw it for the first time when I was a visiting professor in the US, and they said, you know, the hospitals are so busy that sometimes when a patient gets better, we send the patient home without going through the general floor. It was the first time I heard about it. I say, what? What do you do? And then I thought about it, especially when they started to speak about telemedicine and about teams that could go home and could, you know, make sure that the patient takes his medications and slowly improves over time, etc. So there is some form of monitoring, perhaps every single day, perhaps twice a day at the beginning. But, you know, it's much less costly and much more convenient for the patients to be at home with people coming to help them rather than staying in a hospital when it's no longer necessary. So as we know, the hospitals will shrink, the hospitals will have less beds than they have now. But as I said at the beginning, the ICUs will actually expand, and critical care medicine will be a very, very well-established, very appreciated, and very attractive specialty with a lot of intellectual stimulation. It is the best specialty you can think about, and in the future, it will be even more appealing than it is today. So I think I have gone in a big cycle to where we started, and I don't want to be too long. So if you have additional questions, I will be happy to take them.
Thank you, Professor. You have painted a really inspiring and fascinating future for critical care medicine. I just got one question. To the person listening to this podcast, whether he or she is a trainee or a specialist, whether he or she is a doctor or a nurse or a therapist, whether he or she is a clinician or an administrator, whether he or she is an educator or a researcher, or whether he or she is from a high income or a low middle income country, how does he or she prepare for this exciting future that you are talking about? How does he or she contribute and build this exciting future that you are talking about?
Well, they should come to a department and be welcome positively in the department, recognizing what they would like to achieve, but also their limitations. And, I have done it for many years. And when people arrive in our department, as you say, there may be doctors and non-doctors, there may be older or younger than the others. It doesn't matter. We can tell them we are a team. The team approach is of fundamental importance, and we will really help each other. And the team approach is really crystallized during rounds at the bedside. If you do not have good communication, you won't have good rounds. And to me, it's really a way to evaluate the quality of a department. I make rounds with them. And if I hear something like, oh yeah, this patient is getting better and will leave the ICU soon. Oh, that's so good. Let's go to the next bed. Oh, this patient is getting worse. Oh yeah, but the patient is old. You have done what you can. These are useless rounds or hardly useful rounds. But if you start to discuss the mechanisms and why you did this and why you did that, and then of course your assessment at the end, but maybe still with some plans. If the patient is getting worse, perhaps this will be a good end of life, But in any case, we need to have these discussions that could lead to reasonable plans for the patient and their family. So come in the ICU and watch what's going on and go around with the others. And that's the advice I will make to them. And we do it even for the public, when people will come to the ICU after a cardiac surgery, for instance. We tell them, if you like to come to the ICU before your operation, you can come and see how we work. And some people like it very much. Then when they open their eyes in the ICU after the surgical intervention, they recognize what they have already seen. There is nothing to hide in the ICU. When I was young, it was so difficult to enter the ICU. People were saying, oh, no, that's terrible. And you need to have a gown and to have shoe covers. And, oh, be careful, wash your hands once again. Ooh. But, and then the consultant, from surgery or from other specialty, hesitated to go in the ICU. I will disturb them. They are very, very busy there. No, they should come because it's good for the patient to have them. So, and the families should come and stay there. Sometimes I have these discussions with family members who say, oh, no, my father or my mother must rest. I don't want to stay here. What? They don't need to rest all the time. They need to rest during the night, but there is no reason to rest all the time. They will become weaker and weaker if it's the case. We would like to go up. We would like them to go up in a chair and start to walk a little bit. So please stay with them. Tell them stories. Watch TV with them. I had to fight to get TV sets in our department many years ago because the hospital management did not understand how useful it could be for patients who are critically ill. What would they need a TV set for? Yes, the TV set is very helpful for them as it is for less severely ill patients. So I am taking different approaches here, but people should not be afraid to go in the intensive care unit. And as you say, administrative collaborators may be a bit afraid to work in an ICU. They can come with us and we can show them everything, and that will clearly reassure them and make their life easier in the next future.
Thanks, Professor. I have one last question. It's a little bit more personal. So I started off the podcast by saying that you have been there, done that, right? You have seen intensive care and critical care medicine through the decades. You continue to be so passionate. You continue to paint such a beautiful future for intensive care. Meanwhile, COVID, we have seen healthcare workers, intensive care unit workers getting all the burnout. Some people are leaving the sector, etc., etc. So my final question to you is, how do you do this? How do you continue to be so passionate? What word of advice, inspiration would you give to everyone who's out there who needs this, who can go on to imagine the future for the future?
Well, as I tell my students on the very first lecture, I tell them, if you like medicine, and I hope you like medicine, if you like helping others, etc., then critical care medicine is your favorite field, because you will deal with all aspects of acutely ill patients. You will not focus only on the skin abnormalities or on the brain or on the lungs. You will have all of this. It's never boring, never boring. Every patient is different from the other one. And you will love the team aspect, having the chance to discuss with many other people in the ICU and outside the ICU. So how could you be bored? I do not understand those people who say, oh, I should no longer be in an ICU. I'm too old for this. No. Now, your profile may change over time. I'm not saying that you should take nights on call until you are 65 years old. No. Or you don't need to intubate the trachea until the very end. I stopped intubating tracheas a number of years ago because I thought that younger people would do it better than I do. So when you realize that, when people doing it every day start to do it better than you do, allow them to do it. And I am better, I feel better, and I think I am a better person when I give some advices about how to manage the patient. I could not do it when I was a young fellow, when I was intubating the tracheas and inserting lines everywhere. That's no longer my first priority. You can change over time. But saying I have enough of this, I don't understand that. It is really such a beautiful specialty. You cannot be bored.
Right. Thank you, Professor. And on that very inspiring note, we'll end this podcast. And thank you once again to the listeners out there. This has been the AVF Behind the Scenes ICU podcast. It's available on social media, on YouTube, on Spotify, and all you need to do is to share it, like it, subscribe, whatever. But just spread the good word about the future of intensive and critical care medicine.
Okay.
Thank you, Professor Vincent. Thank you.
My pleasure.
Thank you.
Take care.
Take care. Bye-bye.
Bye-bye.